Hello and welcome to Robotics Surgery Insights. I'm excited to be joined today by Dr. Eric Acheson. Thanks for joining me today, Eric.
Thank you, Joseph. Pleasure to be here.
And could you please start by providing a background to yourself and your journey in surgical robotics?
Sure. I'm a general surgeon by trade, background in trauma, but have evolved into more of the general surgery space. I'm located in Austin, Texas. Kind of fortunate in that area because Austin is at the forefront, I would say, at adopting robotic technology. Our community has embraced it wholeheartedly. Some of the very first procedures and technologies utilized have been in Austin, and we are heavily saturated here. For people who do what I do, for instance, there's not a single surgeon in several counties that don't utilize robotic technology. So it's not new to us. We're kind of used to it and, dare I say, dependent on it at this point. During my evolution as a surgeon, it became important for me to transition more of my practice into the outpatient setting, in particular an ambulatory surgery setting. And the reasons for that are just from a business standpoint. I felt it was more important for the surgeon to have more of a lead role and a control role in the practice and how he took care of patients and avoid some of the bureaucracy that we see with major hospital systems. Not necessarily at fault, but just a consequence of having so many layers. And also from the financial control of things as well. So an ownership stake in the facility, which in our area you can have as a surgeon in an ambulatory surgery setting, was important to us. So we developed Surgeon's Point, which is the surgery center which I utilize right now. And we are in the growing process. We are recently launched. We're up and running. We're learning. We're growing. We're trying to figure it out and make best use of practice. In our area, robotics being so heavily integrated into everyone's practice, it's imperative to transition that from the hospital setting to the ambulatory setting. If you don't do that, you're just not going to have the participation because people are comfortable with robotics. They believe in it and they understand the advantages that it can give to the patients. So how to do that? Because there's a cost associated with it, right? Robotics technology has a massive footprint, and that footprint comes with a cost. So now I have a reduced amount of resources that I can pull from. And mainly those resources are the funds of the surgeons who have collaborated to put this surgery center together. So how do we do that efficiently and responsibly from a fiscal standpoint and still integrate the best technology to take the best care of our patients? And that's the dilemma. And that's frankly what's exciting for me on this journey of how to integrate that. One of the products we ran across recently was the Maestro from Moon Surgical. I met them at a conference, just kind of happenstance. And when I took a look at their product and understand how this could maybe bridge that gap for me, we readily brought it into our facility and have been utilizing it for now the last 3 or 4 months. It's been exciting. It's helped me learn best practice and management ways and fiscal responsibilities, how to integrate everything to help us move forward with our goals.
Excellent. And for those in our audience that aren't so familiar with an ASC, what is a typical procedure mix of an ASC?
It's changing rapidly. I mean, even in the short time that I've been involved, ambulatory surgery centers in my area typically were small cases. Okay, think ophthalmology, but if I take it down to a general surgery standpoint, I had an old partner who used to say hickeyectomies and freckleectomies, you know, because he was downplaying the very, very minor things that we would do at an ambulatory surgery center, skin procedures, you know, and up to it even grew to the point in the last 20 years, maybe even less than that, where you would start to implement technology like a laparoscopic cholecystectomy, right? So, okay, now I'm bringing the height of technology into the ambulatory setting and providing the capacity for this type of equipment. But over the last 10 years, it's been remarkable what technology has allowed us to do as we advance this minimally invasive curve, and simultaneously this enhanced recovery that we're seeing across multiple disciplines of medicine. Orthopedics, doing joint surgery, total joints in the outpatient setting is a common thing now. 10 years ago, people would have laughed at you if you even thought about that. Robotic technology, as I practiced in the hospital, the things that when I trained were inpatient procedures and people would stay a week, well, they're going home 3 hours later now. So I do a heavy focus of bariatric surgery. And in the past, people would go to the intensive care unit after bariatric surgery. I do a sleeve, a bypass, a duodenal switch, and the patients are going home within 5 hours after surgery on a routine basis. I'm talking 80% of my patient population. So it's changed dramatically. Hiatal hernias, the more complex things, and robotics has allowed this and facilitated this to happen. Soon you're going to see, and probably are seeing in some places, even types of colon surgeries. Used to, a big incision, 7 days recovery. Now people can go home the same day. So it's really remarkable, and that's continuing to advance.
It really is incredible. When you think about this expansion in terms of the types and complexities of procedures being performed in ASCs, what are some of the main challenges you're facing and having to deal with?
The main challenge is twofold, I would see it. First of all, you have to ensure that it is truly an outpatient case. This is not something where you want to bring a patient in and have a even 20% chance of needing inpatient care, because transfer to a hospital is a real event, and it's a big thing, and people frown on that. So can I do a gastric bypass reliably in an outpatient setting? Well, yes, we can now. And there are other hurdles because, for instance, with gastric bypass, you need to have a certain kind of accreditation to get to before they will allow you to do it in your facility. So we're doing those hurdles too. But overwhelmingly, the biggest hurdle is financial, right? If you think about what a hospital system has to deploy as financial resources, it's immense compared to what we have in a small outpatient setting. This is just surgery. There's no ancillary, there's no emergency room, there's no hospital beds there for people. They recover and they go home. So if I want the best equipment, well, I'm not getting reimbursed like a hospital is. So a cholecystectomy does not get facility reimbursement at an ambulatory setting the same as a hospital, for good reason. Like we are a narrower focus and we can do things more efficiently. So overall, it may be better for healthcare in general to reduce cost, but we still have to be able to fund it and stay alive and keep the lights on. When you bring in robotic technology, that really changes the game, because it can be quite an expense to that. And you have to learn to navigate the waters in a way where, okay, I can cover the technology, but I can also make a profit to keep the lights on and the people employed.
And how have your experiences been with the Maestro system so far?
I think Maestro is extremely interesting because it on the surface level, it helps bridge that gap. All right. So robotic technology at its height, okay, with what we see from Intuitive is just spectacular assistance to a surgeon to get the best practice he can get, and I think any person who has a healthy experience of utilizing that technology will say the same thing. It is an advantage. It is a better tool. But a Porsche may be a better tool than a Honda Civic, right? And have a lot more capabilities. But maybe I don't need to go 0 to 60 in a certain amount of time. Maybe I just need to get to work. A Civic's quite a great instrument and is a healthy financial savings. That scale is magnified when we talk about going from full-scale robotic technology down to what the Maestro from Moon Surgical provides for you. It is not the same capability, but what it does is offers a step back to where you're utilizing not manufactured instruments from the company, but your standard laparoscopic instruments that you would use in basic laparoscopy. But what it does is it allows you that bridge where now instead of having 2 hands, I have 4 hands that I control. And surgeons who use robotic technology have gotten used to that. We're used to using 4 hands. We're used to being in total control. If I look back to my residency when I was doing, let's say, a simple gallbladder, the tech would hold the camera in another arm and be moving and operating at the same time as I was. Now, a much less role, but still they were critical to the encounter. It's frustrating because their mind cannot be your mind, and their skill set is certainly not your skill set. Even if I had an equal partner holding the camera and moving the arm, they're not 100% in sync with what I want. Robotics has got us to where all 4 arms are doing exactly what I want them to do. And we're all in sync. And so the camera is moving exactly where I know my next step is and looking exactly what I'm trying to dissect. The Maestro allows this because now those extra 2 arms, even though they're using standard laparoscopy equipment, are controlled by me. And that really changes the game and allows you more freedom to operate efficiently in the way that you want to.
And what are the main procedures that you're using Maestro for at the moment?
It's neat. Basically anything that you can do standard laparoscopic, which surgeons that trained less than 5 years ago are capable of doing. So you name it, from difficult procedures like a gastric bypass or simple procedures like a gallbladder. You know, people frequently ask me, hey, what's the easiest surgery you do? And off the cuff, I'll probably say, okay, a gallbladder. And then they say, well, what's the hardest procedure you do? And if I think about it, a gallbladder. It just depends on the level of disease that organ has that you're trying to take out. And that can vary a lot. In most bariatric procedures, the moves are complex, or a paraesophageal hernia. The moves are complex, but most of the time it's in relatively healthy tissue unless it's a revision or something. But yesterday I was doing a cholecystectomy, and it was one of those that you wish you weren't in the case once you got in it. And utilizing the Maestro, with me able to hold the camera, or control the camera, not hold it, because I'm holding 2 instruments, and control that 4th instrument, which puts pressure when something bleeds, or hold something for counter tension that allows me to dissect in the plane that I want to dissect in without having to depend on someone else to do that, really was an advantage. The other thing is it freed my tech up. So she's not now holding the camera in the other arm and trying her hardest to do what I want her to do and look where I want her to look. She's preparing the other stuff I need. Do I need suction? Do I need a suture? Do I need a clip or this or that? And it's ready and it's efficient. Stress level goes down. The surgeon is more in control. The more the surgeon is in control, the better the case goes typically.
Great. And could you talk a bit about the adoption process for Maestro compared to your experiences with some of the other systems?
You know, everyone talks about learning curve. I remember when I was proctoring for Intuitive and Robotics, or people were coming to do a case observation with me, and they're like, what's the learning curve? What's the learning curve? I'm like, 1. I mean, it's just a different tool. If you go from this grasper to this grasper, the learning curve is not different. Now, that's oversimplified, obviously, and I'm at the extreme of that. But the point is, surgery is separating tissue. And when you do enough surgery, and some tissues are easy to separate, some tissues are not, but you learn how to hold things in the right way where you can divide that tissue and get to the spot that you want, sew the spot you want, stop bleeding here, or remove the offending agent there. And all technologies, robotics included, have just kind of advanced how we do that. So if I need to pull one way, pull another way and divide in between and see with a camera, that's 4 arms. And so if I'm controlling those 4 arms, that instead of 2, that's a remarkable difference. Not to mention the visualization and the control factor that you get with the robotics that allow for that.
And can you share a specific case where Maestro has made a meaningful difference?
Well, the case I shared yesterday is a great example, but let's take a hiatal hernia. So in my practice, I've had just full-fledged opportunity to utilize robotics at any of the hospitals that I go to. It's there. It's not foreign concept. Everybody has it. Everybody utilizes it. And it's a great advantage. So you become accustomed to that type of operation. And it is different because you're controlling 4 arms and so on and so forth. To take that step back, right, is I think just as hard for surgeons to embrace as taking the step forward, because it's a change, and surgeons are they're kind of reticent to change, right? So, but to take that step back and go back and do something that has some complexity with intracorporeal suturing and those types of techniques, where you kind of have to relearn, okay, this is how I suture and I don't have a wristed instrument anymore. Having control of all 4 hands is a big help. A hiatal hernia is a great example. In that case, there are small incisions for those not familiar with actually doing it. And you're operating at the top of the abdomen where there's just beautiful anatomy. The esophagus is going through the diaphragm. The heart is beating right on top of you. The aorta is right underneath you and you're dissecting right on top of the aorta. The vena cava is right to the side and you're desperately trying to avoid that, even though you're throwing sutures within millimeters of it. And the diaphragm, which moves constantly during the whole thing, is right there. So to do that, you need to be very precise and very accurate. When you control those 4 arms, and that camera is right where you want it because you put it there, and the 4th arm that you're not actively controlling, but passively controlling, that Maestro allows you to do, is retracting the anatomy precisely the way that you want it. It facilitates taking that step backwards and, okay, now I have to sew this manually, the old-fashioned way, which is funny to say, laparoscopically. It really helped me go backwards from that. And I say backwards because the technology is a step backwards. But if you look at the efficiency and what it can do when you're paying the bills, is a huge step forward.
So you've covered a lot, sort of the potential benefits for ASCs in adopting robotics. What specific recommendations would you give to other ASCs that are considering, switching to robot or utilizing robotics, or Maestro in particular for their practice?
Well, and this is what I'm going through right now, right? So we're building our center and we need to recruit more surgeons, right? We need more people. The more cases you get done efficiently, the better you're going to produce as a facility. And I'm talking about from a financial standpoint. And there is a very real potential for the whole thing to fail, right? And for bankruptcy and all the doctors lose their money and go kind of crawling back to dependency on the hospital system to do everything for them again, right? And I think there's a fear of that from surgeons, and they know that. And they're comfortable, at least in my setting, with the robotics technology. So how do I bring that to the facility and make a surgeon comfortable to perform his procedures there, give him the technology or her the technology that they need to accomplish best case management and medical care for their patient, yet still do it in a financially efficient way? In my facility, we have, for instance, a intuitive machine. Some of the more complex things that we do, I still like to utilize the machine. When I need a wristed instrument to sew on the ceiling or do something very advanced, or let's say a patient with a BMI of 60 where I need a little more control and retraction, I will utilize that machine. But if I can do that case a little more simply with some assistance from the Maestro, that frees my tech up completely, that gives me 4 arms of control and allows me to do the whole case effortlessly, then that's a big boost. And I can, if I have one in each room, which we do, then I can go back and forth, and that improves time efficiency as well. So it's really unique. If you take yesterday, so I did 3 cases in the ambulatory center yesterday. All 3 were doable on the Maestro system. So what do I choose? Do I choose the Maestro or the Da Vinci system to do it? Well, first of all, what's safe for the patient, and can I get done best case for the patient so that they go home, have a great recovery, and have a low risk of complication? When I checked that box, it was equal for the most part. So then 2, which case is more cost effective? Because remember, I'm paying for the bills in part, along with my colleagues, and I'm responsible to Dr. X, who's a joint investor in this center with me. So as a person who is interested in fiscal responsibility, I chose the Maestro, and in case number 1 and 2, it saved $900 each case, and in case number 3, it saved about $550. So on the surface, you know, a little bit less than 3,000, you know, 2,500, something like that. Well, but if you multiply that over multiple surgeons over 365 days to the year, then you've really changed the bottom line to your center. And when you're fighting to break even, if you just want to get from going into more debt to actually producing some revenue and maybe distributing checks to your surgeons, that's a big difference. And I think if people embrace that, Maestro can be that bridge. It's not, in my mind, the total solution, but it can help you bridge that gap for people who want to offer advanced technology in the ambulatory setting. And also, that advanced technology allows you to bring some of the cases that would normally be relegated to the hospital system into the outpatient center. Okay, if I have a better percent capability of doing this procedure as an outpatient, then that's how I want to do it. And I think it's better for the patient. So it opens up a lot of doors, actually.
I think you've summarized it perfectly. Maestro enables more patients to get the advanced surgical treatments because not everyone requires a Da Vinci. There's this large base of people and procedures where Maestro can provide exactly what they need and then ultimately deliver the better economics for the ASCs.
That's correct.
The final question really for you is sort of looking to the future. What would you say excites you the most about the trajectory of robotics in surgery, especially in the ASC space?
Well, I think it allows the continuum of this spectrum. As we're seeing, there was a point in time, and I can't quote the exact accuracy of this or how it holds today, but it was a year or 2 ago where I read a statistic that in the US, 7% of cases were being transitioned from the inpatient hospital setting to ambulatory surgery setting annually. So if you compound 7% annually, well, I'd love to do that for my financial profile if I had 50 years to do it. But you can imagine what it's doing for the hospital. And so the landscape is shifting. And it's, if you look at it from a national standpoint, it is more, if everybody's having a problem paying for healthcare, well, if you can reduce costs and make it efficient and good for the patient, then you want to do that. So I think that will continue the trend. But the technology has to keep up. I mean, minimally invasive technology has allowed us to do something like a bypass or a total knee that was heretical to think of in the past. And now we do that routinely in the ambulatory setting. So as that curve continues and we become more and more efficient, the tools that we utilize are the key to advancing that. And I think robotics has shown us that. In the inpatient setting or in the hospital setting, even the outpatient hospital setting, where I am, people routinely use robotics even when not necessary. I made a statement, years back where if you need to cut my toenails, then, use the robot because that's how much I like the machine, right? And it's kind of become that. When you use it, you become used to it and that's your go-to. But at the hospital setting, I don't have that fiscal responsibility. So it's not in my train of thought. I'm more self-centered in, well, what do I need to get this case done? But if I think about it from an ownership standpoint, and if a hospital system thinks about it from a hospital system, how do we increase efficiencies and reduce costs in our own setting? There has to be an in-between non-robotics and robotics. And where is this gray area? And it's going to continue to advance on the far end of the spectrum, right? The data that they're collecting now is astronomical. And as AI comes into the platform, things are going to be ridiculous. But the in-between area, I think, is where you can maximize advances on a financial scale.
Thank you very much for your time today. It's been great talking with you.
You're welcome. Yeah, thank you for having me.